Welcome to Nursing 542 Module 8, where we'll discuss neurological assessment and diagnosis in the primary care setting. First, we'll review the basics of a neurological assessment, then discuss common neurological complaints, and then explore various neurological conditions that you're likely to see in the primary care setting. I always want to give you the red flag conditions so that you'll be aware and be able to recognize them if patients present with these warning signs. Headaches typically are no huge concern, but descriptions such as a thunderclap headache or the worst headache ever, if they're accompanied by abrupt changes in level of consciousness, or if you're finding focal neurological signs on exam, and those are major red flags. Acute bacterial meningitis, nuchal rigidity, I think, is your textbook symptom that you're looking for there, and also fever, severe headache, temporal arteritis, severe headache located on one temple, and you'll oftentimes find a red cord-like temporal artery and scalp tenderness. Stroke, chronic subdural hematoma, and subarachnoid hemorrhage, and acute narrow angle closure glaucoma are also red signs, red flag conditions that you'll want to be aware of. The general neurological assessment consists of the mental status check, cranial nerve function evaluation, and assessment of motor reflex and sensory function. So we'll go over these individually, but these are the major components of the neurological assessment. Mental status evaluation. Most of the components of the mental status evaluation can be assessed simply by completing your typical interview of the patient regarding the history of present illness, past medical history, family history, social history, etc. When the patient's chief complaint does not suggest a neurological disorder, then a quick 5-minute mental status evaluation can be completed and should be adequate. There are multiple mini mental status evaluation tools available. There are several examples in our Kennedy text. If there is an indication of a mental status abnormality identified through your interview or the mini mental status check, then of course you would perform a more thorough mental status evaluation. As noted in Harrison's text, all patients should at least have a cursory check of their cranial nerves completed with each assessment. See the bare minimum here on this slide. A comprehensive cranial nerve function assessment, typically only done in a specific neurological when a specific neurological issue is suspected, includes the following. For cranial nerve 1, the olfactory, you have the patient with their eyes closed see if they can identify a common odor such as coffee, mint, or orange. And again, that's with their eyes closed. For cranial nerve 2, the optic nerve function is assessed via visual acuity testing, visual field testing, and fundoscopic examination. For cranial nerves 3, 4, and 6, extraocular movements and pupil size, shape, and reaction to light and accommodation are assessed. For cranial nerve 5, the assessment is performed by applying light touch to the forehead, cheek, and chin on alternating sides of the patient's face and confirming that the sensation is felt equally. The corneal reflex is tested by asking the patient to look in one direction, introducing a cotton wisp from outside of the visual field on the other side, and watching for a reflexive blink, then repeating on the other side. For cranial nerve 7, facial symmetry is key. Ask the patient to smile, clench their eyes shut, raise their eyebrows, and puff out their cheeks. Finger rub or whisper test may be utilized to test the function of cranial nerve 8. If an abnormality is detected, then additional assessment via the Weber and Rin tests with a tuning fork is appropriate. For cranial nerves 9 and 10, look for symmetry of the palate and uvula at rest with phonation and swallowing, and check for the presence of a gag reflex. For cranial nerve 11, check for symmetrical motor strength in the trapezius and sternocleidomastoid omastoid, geez, oh man, muscles by asking the patient to shrug their shoulders and rotate their head while you apply resistance. For cranial nerve 12, check the tongue for symmetry and fasciculations. What a word. That means flickering movements. And confirm that the tongue stays midline when protruded. There are multiple YouTube videos demonstrating cranial nerve testing if you want a visual example to practice along with on a lucky spouse or friend. There are also various acronyms to assist you with remembering the names of the cranial nerves. Examples, this is the one I used way back when, was an old Olympus towering top, a Finn and German viewed some hops. Another is ooh, 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 to touch and feel very good velvet, such heaven. But there are multiple others, and some are a bit nasty, so I won't share them all here. But if you're one that, learns that way with an acronym would help you, then you can Google that. A motor examination. As part of the motor examination, you'll want to look for symmetry in strength and tone, as well as atrophy in all major muscle groups. Muscle strength is typically graded on a 0 to 5 scale. Having a patient perform tandem gait, which is where the heel of one foot touches the toe of the one behind it, walk on their toes and then their heels. It's a good way to evaluate lower extremity strength and function. There are several exams that quickly and easily determine a general sense of motor function, such as the get up and go evaluation that can be utilized if there's no major concern about neurological issue and you're just wanting to get a general assessment. Reflexes. Muscle stretch reflexes are graded 0 to 4, with 0 being absent, 2 being normal, and 4 being clonus. The plantar reflex is tested by running a tongue depressor across the lateral aspect of the patient's sole, beginning at the heel and crossing over the ball of the foot to the greater toe. A normal reflex is plantar flexion of the toes. Babinski sign is an abnormal finding and it occurs when the toes flex and extend in response to the cutaneous stimuli. Sensory. With a patient in whom you suspect a lesion, all aspects of the sensory exam should be performed to assist with pinpointing the lesion location. In the vast majority of your patients in primary care, confirming intact sensation to light, touch, and temperature in each distal extremity will suffice. Here is a list of the most common presenting complaints that you'll receive from patients suffering a neurological disorder. 90% of all headaches have no pathological etiology. You should assess headache pain just as you do any other pain with the old cart method. Family history is also important to obtain when assessing headaches. Dizziness and vertigo are frequently used interchangeably, but they are actually different symptoms. Dizziness is when the patient feels unsteady and has a sensation of movement within their head, feels lightheaded and weak. Vertigo is when the patient feels as if they or their surroundings are moving, rotating, or spinning. Both may be accompanied by nausea, vomiting, and unsteady gait. Potential causes of confusion include delirium, dementia, metabolic disturbances, infection, ischemia, and hypoxia. A resting tremor occurs, as the name implies, when an extremity is at rest and ends with purposeful movement. An intentional tremor occurs with attempted voluntary movement. Essential benign tremors are typically intentional tremors, whereas those present with a disorder such as Parkinson's, for example, are resting tremors. Seizure disorders. Boy, I'm having difficulty articulating this morning. There are multiple subcategories of seizures, and there are multiple causes of seizures other than epilepsy. These include drug overdose or withdrawal, infections, tumors, brain defects, metabolic imbalances, fever, and trauma. The most common cause of a seizure in an older patient is a stroke. Most seizure activity occurs in young children related to fever and those over age 65 related to cerebral vascular accident or stroke. Here you see that epilepsy is defined as 2 or more seizures caused by a central nervous system disorder. In primary care, your initial assessment should be to determine if the patient did indeed suffer a seizure, and if so, what the underlying cause of the seizure was. An accurate description of the event from a witness and patient's description of symptoms before and after an event help to determine if it was indeed a seizure. If you do suspect a true seizure occurred, then you will want to determine if there is a non-neurological cause. This is a list of the potential diagnostics you'll run to determine if there is a non-neurological cause for a seizure. Of course, you won't do all of these on every patient, but will individualize them. For example, in a patient with risk factors for cardiovascular disease, you'll run an EKG. For patients in whom you suspect central nervous system infection, then you may do a lumbar puncture. If you're suspicious for a brain tumor, then you'd order an MRI with contrast. If you have a patient who has been diagnosed with epilepsy previously and is treating with anticonvulsants, then you'll want to draw a drug level to assess for therapeutic levels or toxicity. While an EEG is considered the gold standard diagnostic for epilepsy, a normal EEG does not completely rule out epilepsy, as approximately 30% of patients with epilepsy will have normal EEGs. Your job as a primary care provider will be to identify any non-epilepsy cause of a seizure and treat or refer as appropriate. For a patient in whom you suspect new onset of epilepsy, you will refer to a neurologist. Parkinson's disease. It's a chronic progressive neurodegenerative disorder of the basal ganglia in the central nervous system with unknown cause, more common in men. Average mean age of onset is 57, and it's the second most common neurodegenerative disorder, secondary to Alzheimer's. There's an estimated 1 million people affected by Parkinson's disease in the United States. Approximately 40% of patients with Parkinson's become disabled or die within 15 years of onset. Diagnosis of Parkinson's disease is typically made based on history and physical exam. There is no set diagnostic. Symptoms typically develop unilaterally and asymmetrically. MRI of the brain may exclude structural brain lesions but does not confirm a Parkinson's diagnosis. These are the symptoms that you'll see in a typical Parkinson's patient. A resting tremor, that's key to know. Not an intentional tremor, but a resting tremor. Pill rolling is when they are rubbing their thumb and their pointer finger together like rolling a pill. Rigidity, you hear about the term cogwheeling utilized frequently. Bradykinesia, slow movements. Masked facial expression, so oftentimes they don't have your common typical facial expressions with emotion. They'll remain flat. Gait disturbances, the shuffling gait is typical, and flexed posture and kyphosis are common among Parkinson's patients. Stroke or cerebral vascular accident. It's the number one neurological cause of mortality and morbidity in the U.S. Males are at greater risk, as are African Americans, Native Americans, and Hispanics. Strokes are categorized as either ischemic or hemorrhagic. The overwhelming majority are ischemic. Hemorrhagic strokes are typically related to a traumatic bleed, a bleeding disorder, or hypertension with a ruptured artery. The risk factors for stroke are age, positive family history, hypertension, diabetes, atrial fibrillation, a history of TIAs or transient ischemic attacks, hyperlipidemia, cardiovascular disease, smoking, alcoholism, obesity, and sedentary lifestyle. In the primary care setting, patients will typically complain of weakness, numbness, or paralysis, severe headache, and perhaps cognitive difficulties will be evident. Ideally, you will not be diagnosing strokes in primary care. However, symptom onset can be gradual. History of present illness is key. Nature of the onset, nature, timing, and duration of symptoms, whether symptoms are improving, worsening, or stable. Symptoms that last no more than 1 hour and resolve are typically transient ischemic attacks, known as TIAs. Patients with a history of TIAs are at greater risk of stroke. You'll want to aggressively address stroke risk factors in patients who have experienced TIAs. For diagnosing a stroke, you want to do, as I mentioned, a comprehensive history, a neurological assessment, emergency CT, emergency transport if you identify a patient in the midst of experiencing a stroke. Timing is of the essence. An MRI is more effective at identifying small ischemic lesions, but typically a CT is done, and then you'll want to get like CBC, PT, and PTT to check coagulation, electrolytes, BUN, creatinine, glucose, calcium, magnesium, sed rate, EKG, and a chest x-ray. Bell's palsy, I'm putting this here in this section of the lecture because it's commonly diagnosed once a stroke has been ruled out. Bell's palsy is peripheral facial nerve palsy, and the patient will have an acute onset of unilateral facial weakness and paralysis with a drooping eye and mouth and facial asymmetry. Brain tumor. Brain cancer is rare. It accounts for approximately 2% of all cancers. So hopefully you won't be diagnosing this in too many of your primary care patients either, but it's good to be aware of because it is such a tragic disorder. It occurs in males more than females. The peak age range for diagnosis is 65 to 79. Radiation is the only known risk factor, but there appears to be a genetic factor in certain types of brain cancer. Patients with a history of chemotherapy and radiation therapy are at greater risk of developing brain cancer. More than 50% of patients with a brain tumor will complain of headache, nausea, and vomiting may also be present. Approximately a third of patients with brain tumors will complain of memory loss, cognitive changes, and motor and speech deficits. Seizure activity can occur. Anytime you have a new onset of seizures in a patient over 40 years old, you should work to rule out a brain tumor. And there may be focal neurological changes depending upon the location and size of the tumor and the area of the brain impacted. Most of the diagnostics that you will perform in primary care will be aimed at ruling out other potential diagnoses. In primary care, I would recommend that if you have a patient in whom you suspect a brain tumor, that you consult immediately with an oncologist and or neurosurgeon. That way you can obtain the imaging studies that will be most helpful for them when determining treatment options, surgical approaches, etc., and their patient can avoid duplication of diagnostics then. Of course, as far as diagnosis of a brain tumor or any type of tumor, you have to have the actual tissue, histology, biopsy for a definitive diagnosis, but gadolinium enhanced MRI is the neuroimaging choice for identification of a mass when you're looking to evaluate for a brain tumor. Degenerative neurological disorders. Covering here is multiple sclerosis and ALS or Lou Gehrig's disease. There's 4 subsets of multiple sclerosis. Multiple sclerosis, MS, is commonly diagnosed most commonly in patients between 30 and 50 years old. The later the onset, the more progressive the disease course tends to be. Women and Caucasians are at greater risk. The cause of MS is unknown. There is known to be a genetic component, but environmental, autoimmune, and viral factors are thought to play a role as well. As far as ALS, 5 to 10% of it is inherited, and the remaining cases occur randomly. Possible causes being investigated include genetic mutation, metabolic disorder, and immune system dysfunction. The 4 types of multiple sclerosis, the relapsing remitting subset, that is the most common subtype. Progressive, primary progressive, secondary progressive, and progressive relapsing are the other subtypes of multiple sclerosis. The symptoms in ALS typically occur symmetrically. That's the big difference between MS and ALS as far as presentation. Patients with MS can present with any combination of the symptoms listed here. Patients may not have any of the symptoms when they're in your clinic if they're in remission. However, with multiple episodes, they may retain more of the symptoms in between exacerbations. That is, if they have the most common relapsing remitting subtype. Neither MS nor ALS have any definitive diagnostic test. ALS is diagnosed when symptoms are progressive without remission and suggestive of upper and lower motor neuron dysfunction, and when no alternative explanation can be found. MS is also clinically diagnosed. The diagnosis is based on the patient history, neurological examination, and diagnostic tests that are consistent with the existence of two or more lesions in two or more areas of the central nervous system. With MS, the course of the disease determines which subtype is diagnosed. For example, relapsing remitting is diagnosed if the patient has experienced two or more episodes of exacerbation lasting longer than 24 hours and separated by at least 1 month, with remission of the majority of the symptoms in between. Because the diagnosis is purely clinical and because there are multiple other diagnoses that can mimic a degenerative neurological disorder, I would recommend, at the bare minimum, consultation with a neurologist. Alzheimer's disease. As many as 5 million people in the U.S. are estimated to be suffering from Alzheimer's disease. Although the specific cause remains unknown, there are two types of lesions typically found in the brains of Alzheimer patients: neuritic plaques made up of beta amyloid and intracellular neurofibrillary tangles. Thus, the thought is that AD, Alzheimer's disease, may be triggered by a defect in the metabolism of beta amyloid precursor proteins, but like I said, that has not been definitively determined yet. Alzheimer's disease may be difficult to diagnose early on, as patients may be able to correctly respond to general questions and symptoms can be vague. It has insidious onset, which makes it more difficult to diagnose, but the hallmark symptoms are impairment in learning abilities, inability to recall recently learned information, difficulties with reasoning, word finding deficits, impaired visual, spatial abilities, and behavior and personality changes. The only definitive diagnostic to date for Alzheimer's is the identification of pathology in the brain on autopsy. Most of the diagnostics that you'll perform in primary care will be done to rule out other potential causes of dementia, such as infection, trauma, structural CNS disorders, metabolic disturbances, anemia, depression, drug and alcohol abuse, medication side effects or toxicity, and psychiatric disorders. Alzheimer's disease is generally a diagnosis of exclusion, diagnosed when other potential disorders are ruled out as contributing to the dementia. Peripheral neuropathy. Peripheral neuropathy can occur for a wide variety of reasons. Diabetic neuropathy is one of the most common causes, but other contributing disorders should be ruled out, such as vascular. It's a decreased distal sensation. They'll have distal muscle weakness or atrophy, and decreased or absent ankle reflexes. Diagnosis of peripheral neuropathy is made via electromyography or nerve conduction study testing. In primary care, most of the workup that you will do will be to determine potential causes. You'll be looking for a history of exposure to toxins, medications, alcohol or drug abuse, nutritional deficit, or labs to identify underlying cause. Restless leg syndrome is pretty self explanatory as far as the symptoms: an urge to move the legs. However, it can also impact the upper extremities. Symptoms are typically peak at night between midnight and 3 a.m., and there is discomfort associated with the urge to move the extremities and is briefly relieved when the limbs are moved. Specific cause of restless leg syndrome is unknown, but there is a genetic aspect to it. Peripheral neuropathy and iron deficiency are believed to contribute to development of RLS. There are multiple medications that appear to make restless leg syndrome symptoms worse, including antihypertensives, antidepressants, and antihistamines. As it seems is the case with many neurological disorders, there is no specific diagnostic for restless leg syndrome. You will want to screen for anemia, and you may want to consider a sleep study. RLS is a diagnosis typically made clinically and based on exclusion of other disorders. I know we've covered a lot of topics here this week, so please post any questions you have under the course communications tab, and I'll try to address those. Thanks.